who was announced in the program. Unfortunately, so Guatemala is one of the PIs of the ASSISTENT registry. Unfortunately, he was unavailable on very short notice. So I'll try and do the best to present the interim analysis and the preliminary data of the interim analysis of the ASSISTENT registry. So yeah, you have the slides on. Excellent. So this is the forward. So for all of you that are not familiar with this study, with this registry, this is actually something like a prospective post-market registry, so nothing very complicated. So the idea is to collect data of success and safety of the use of the Credo stent. So this is all about routine clinical practice, and when you look at the evaluation of primary outcomes, this is nothing uncommon, so we are looking at the technical success mostly and at the peri-procedural and post-procedural vascular events in terms of hemorrhagic and ischemic events of up to 30 days from intervention. So what about inclusion criteria? As this is a prospective registry, there are actually no special inclusion-exclusion criteria. They are all according to the IFU. And if you've been listening to Ben Eckert before, so we had a lot of problems as in every other country after visit in Sampras in reimbursement. So there are very strict IFU criteria in use of intracranial stents. So mostly patients should have a high grade, meaning over 70% intracranial stenosis. That should go with a significant circulatory disturbance, meaning that if they have imaging, they should have some kind of hemodynamic or combined at least infarct pattern, and they should have symptoms in spite of intensive medication therapy. That means that all those patients should have at least 2 clinical events, so 1 clinical event usually without medication, and then they go on medication, and then they should have another clinical event before we think about stenting them. So patients should be over 18 years old, like in most of the studies, and after Sampras, so lessons learned, the last stroke should have occurred at least 7 days before intervention, and the MRS should be equal or below 3 to be entered in this registry. Exclusion criteria, actually no real exclusion criteria except acute treatment, and this is only because there's a parallel study that actually finished recruitment, but the acute study that looked at acute treatment with the Credo Neurospeed system, so this registry excluded those patients. So there are 2 principal investigators, Professor Tamala from the neurology side and Professor Chapeau from Essen from the neuroradiology side. At the moment, there are 15 active centers in Germany. I won't go through all of them, but one interesting thing when you look at the enrollment overview, we have quite a lot of centers that actually enrolled more than 10 patients. So in my point of view, this is nothing what we sometimes see like a pseudo multicentric study where there's like one center that almost all the cases. I believe we don't have an even spread here, but we have many centers that did a lot of cases. That is actually good for a study. So in this interim analysis entered 50 cases. 75% of them, 74 exactly, were female patients, and we have a quite young population, in the mean 67 years old. When you look at the vascular risk factors, they are actually as expected. We have almost all of our patients presenting with arterial hypertension, hypercholesterolemia, and diabetes mellitus. We have little patients with coronary heart disease, and actually we have very little patients that smoke. This is something what we see in most upcoming studies. So people stop smoking. This is something good. What it means for ICAD, I don't know yet. How about the target vessel location? Exactly as expected, we have most patients with lesions in the V4 segment, directly followed by M1 and the intradural ICA, so the preliminary location for ICAD, and all other locations are really in very low numbers, so everything as expected from anatomical point of view. Pattern of ischemic stroke when patient entered the study, so before treatment. So in contrast to what I told you are the IFU criteria, we have most patients, 20 patients, meaning 40% of patients that presented with embolic pattern, not hemodynamic pattern, directly followed by 18 patients with hemodynamic patterns, and the rest is like either combined pattern or something else that I can't actually tell you what is in terms of imaging. How about pre-stent medication? A very important and interesting point. So we have 42 patients, so 84% of patients that had double antiplatelets before treatment. We have 7 patients, 14% of patients that only received mono antiplatelet therapy. I can't tell you what platelet they exactly got. And then we have 1 patient that didn't receive any antiplatelets. So this is certainly a very interesting case, but like in this preliminary analysis, I can't tell you further about that. How about the response? So we have 40 patients that actually were tested and had a positive response. We have 6 patients, 12% of the population, that were tested but had no response. I can't tell you if they have been converted to another medication, probably not at the point, and 4 patients where we actually don't know if they have been tested and don't know their response status. So how about the primary endpoints? And I'll first talk about the technical success, and in this registry the technical success is some kind of composite endpoint. So it's composed of possible stent placement and either improvement of the hemodynamic situation visually assessed, or stenosis or rest stenosis grade after PTA and stent of less than 70%. And in this case, for this endpoint, we have ECRF analysis and core lab analysis, and they're the same. So we reached technical success in almost all patients. Only in 1 patient the stent placement was feasible, but the rest stenosis was over 90%. So in that case, no improvement of the hemodynamic situation. How about the hemorrhagic events in those studies? So we do have hemorrhagic events. So now we don't look at the number of patients, but at the percentage, just to point out. So when we look at the symptomatic ICH, we have 3 patients, 6% that showed bleeding during treatment, and each 1 patient that had bleeding in the hospital follow-up and in the follow-up after hospital discharge during the first 30 days. And we have 1 patient that actually had an asymptomatic ICH during treatment. Maybe even more interesting, how about the ischemic events? So in terms of transitory ischemic attacks, there's each 1 patient that showed a TIA during treatment and during non-hospital follow-up. When we look at the non-disabling ischemic stroke, we have 1 patient that had problems during treatment and 2 patients that showed transitory ischemic lesions during hospital follow-up. And probably the most interesting part in this slide is the disabling ischemic stroke. There were 8%, so 4 patients that had disabling ischemic strokes all during treatment. Actually, and that is interesting and will be especially interesting when we have the whole analysis of all the patients, only half of those patients had lesions in the target lesions, so meaning in the stream of the stented vessel. That's very interesting because we usually don't know what's the underlying pathology when we do have like problems in other target regions. One other thing that is interesting, that all patients with ischemic events received double antiplatelets, so the largest group of the population that had double antiplatelets, but only 44% of those patients, so with double antiplatelets and ischemic problems, had a negative responder test. So this is something interesting. So they had double antiplatelets, but probably one of those platelets didn't work. Maybe this is an underlying reason for the ischemic events. We don't know yet, and we'll certainly have to look further in the data. How about the severe and unsevere adverse events? So probably most interesting are the procedure-relating severe events. There were five of them. So there was one, so it's just like what was written in the ECRF, one probably brainstem infarction due to emboli. This is a case with a basilar stenosis. There was one occlusion of the radial artery at puncture site that had to be thrombectomy. That was actually my fault, but the patient was fine afterwards. We had two ICH, so one in a pre-existing infarction and one with an SAH that led to hydrocephalus, and one patient that awake with new stroke, so with severe aphasia after treatment in general anesthesia. When we look about at the procedural-related severe adverse events, there were 3 of them, so 2 instant thrombosis. So we heard Bernd Eckert talking about if instant thrombosis after intracranial stenting is a severe adverse event. In this study, it was said that it had to be reported as a product-related severe adverse event. So 2 of those were instant thrombosis, and 1 was a dissection after neurospeed navigation in a complex vasculature. In the end, so after 30 days, 4 patients of those 50 patients died. 1 patient died because of a malignant large media infarction. 2 patients died because of pneumonia, and 1 patient died because of ICH combined with SAH. So this is one of the patients. Do we have a pointer? No. One of the patients of the procedure-related SAE group. So this is doubled in this case. Last slide, and probably the most interesting, is the clinical benefit of the patient, unfortunately. So this is preliminary data. There's still a lot of discuss. So this is the MRS distribution at baseline, so before treatment, at hospital discharge, and at the end of the clinical follow-up, so at 30 days. So at the beginning, we had 74% of patients that had an MRS of 0 till 2, and at the end 68% of patients. So we have like a little decrease of clinical benefit, so it's probably not that much as we've seen in Sampras and Visit, but still. So one thing I'd like to point out that is interesting, that we do have quite a lot of patients that had an MRS above 3 at the beginning of the study, so those patients should have been excluded from the study. They haven't. It was a prospective registry. You could have entered those patients, but I believe when we have final analysis, it will be interesting to not only look at the absolute data, but at the MRS shift as well, to see like from where those patients came that declined clinically. Thank you very much.
Thank you very much for your talk.
Yeah. Sorry.
No.
How are you?
Go ahead.
Go, please. You too. You go.
Thanks very much. I have a few questions, but maybe the audience first. No questions so far, and on the other screen we have no questions. So my first question would be, you mentioned the 44% of ischemic events outside the target vessel, where we don't have any concrete ideas, but what do you guess what would be the most likely reason for that? Because this is really a matter of concern, I think.
Yeah, so actually, I just can guess because I just know this data and don't know anything about the patients, and especially those patients where these things happen. So we usually see when we have a complex anatomy, when it takes some time to like pass the aortic arch, we see like ischemic lesions on the other ICA territory, probably because we did a lot of maneuvers in the aortic arch. So this might be one reason. Maybe, on the other hand, when we have like general anesthesia and the pressure got very low, and we have maybe not so severe, but ICAD as well on the other side, this might lead to some hypoperfusion, but I'm only guessing. I don't know, actually.
Yeah. I have another question. When we talk about the Sampras trial, we say that probably including embolic patients was an error, was a mistake, because the real indication for intracranial stent, the main indication is the hemodynamic stenosis. You said that you have a high rate of embolic patients in this registry. can be hit something that don't help to reach the expected result?
Probably, of course. So in our institution, so we take part in this registry. We actually stick to the IFU and only include patients that have at least a combined imaging pattern, so hemodynamic and maybe embolic lesions. And I believe that maybe in the end you can do a subgroup analysis and look at the patient that only had embolic or some combined lesions, but this will not have the power to answer the question. But this is like always the problem of the prospective registry, not a real like randomized trial, that you can enter patients that maybe don't fit those criteria quite well if they are not defined at the beginning. But I'm completely with you. This will be a problem in the end with the results, or might be a problem.
Thank you.
And the the stent occlusion you saw was only at the acute phase, not no occlusion in the long term.
Yes.
Okay.
So 2 stent occlusions in 50 patients, and all happened during the procedure. But it's only 30 days follow-up, so we know most stent occlusions happen like in the first couple of days, but still like only 30 days of follow-up.
Thank you.
Do you know that if these patients received also bailout therapy, medical therapy, like?
I don't know.
Okay.
I can't tell you. Sorry.
Okay, thanks again very much for this nice overview on the ASSISTENT trial, Maxim, and we'll